Thanks for the introduction. And this is my disclaimer slide. And as you all know, molecular applet mismatch outperforms conventional antigen mismatch in risk assessment. In order to prove that, we used a cohort of 626 patient donor pairs who underwent renal transplantation in Saskatchewan in Canada. And we follow up these patients for 10 years for development of donor-specific antibody. Out of this study, we concluded that we were able to identify the applet mismatch cutoff for each locus. And as you can see here, that each locus has a different applet mismatch. We further stratified this patient into 3 different groups, depend on the applet mismatch group. And I'm not going to go into further details because we already presented this last year. I'm interested more is what we have done this year. And in order to proceed, I would like to remind you about the indirect allo recognition. But please excuse me, and I'm going to change the name slightly to become indirectly recognizable. And here you can see that there is a donor kidney cell, and this donor kidney cell expresses an HLA molecule. The green circle here represents a surface HLA peptide or a surface HLA epitope, and the red here represents a core HLA epitope. So at one point, this HLA will become shed. It will be taken by the antigen-presenting cells, say, for example, the B cells, through the B cell receptor, which recognize the surface epitope, and this will become internalized. And once it becomes internalized, it will release the core epitope. This core epitope will become the HLA epitope because it's going to bind to the HLA binding or peptide binding groove, and this will result in activation of the CD4 positive T cells. So if you have a software that can predict this HLA epitope, then we can call this software the PIRCHE. So let's see how PIRCHE works. In the first phase of the PIRCHE analysis, it actually looks at all the donor HLA epitope, which I mean the core epitope, and it isolates them out. So in this case, you can see that the donor have 8 different HLA epitopes. Then it starts to subtract the epitope that are considered self, because the patient HLA molecule has them. And here you can see that 4 of these self epitopes has been subtracted. And this left with only 4 is considered the allo peptide. Now we will take this allo HLA epitope and we'll see which of them will be bind to the patient HLA class 2 molecule. And here you can see 2 of them only bind, and the other two did not bind. So this now will result in activation of CD4 positive, 2 clones of CD4 positive T cells, and the patient would take a score of 2. So we hypothesized that a high PIRCHE score will correlate with increased likelihood of T-cell mediated rejection, while a high epitope mismatch score will be more strongly associated with incidence of antibody mediated rejection. Why we think that? It is because T-cells are directly engaged in recognizing mismatched peptides presented by the HLA molecules, whereas epitope mismatch typically stimulate humoral response leading to donor-specific antibody formation. So in order to test this hypothesis, we grouped these patients into 2 groups: donor-specific antibody, which are the patients who develop donor-specific, and non-donor-specific antibody. And you can see here, we looked at only 3 locus, and you can see here that the patient had higher applet mismatch score who developed donor-specific antibody. And then when we look at the PIRCHE score of this patient, we found that also these patients have high PIRCHE score. So the next step is we divided the cohort of 600 patients into donor-specific antibody group, which consists of 105 patients, and then this were subgrouped into antibody-mediated rejection and combined antibody and cell-mediated rejection. And you can see that not all the patients who developed donor-specific antibody developed AMR or CMR. And then the other group was CMR group, which is 74 patients. And then there was the rest did not develop rejection, but only 173 of them were biopsy proven. And you can see here that that when we looked at the compared the applet mismatch score to the antibody-mediated rejection or cell-mediated rejection, you can see that the patient who develop antibody-mediated rejection have significantly higher applet mismatch score compared to the no-rejection group. And also, when you look at the PIRCHE score, here you can see that the picture has been reversed, and the patient who develops cell-mediated rejection have higher PIRCHE score compared to the no-rejection and compared to the antibody-mediated rejection. And now this is the best figure, is that when you have low mismatch, low applet mismatch and low PIRCHE, these are the patients that were doing great, which are the blue line on the top. And if you have a high applet mismatch and high PIRCHE score, these are the patients that did worse. And then you have this patient in the middle, which we are still investigating, but we are suspecting that this patient has some risk stratification with their immunosuppressor, which we are still looking at. So epitope mismatch and PIRCHE scoring can replace the traditional antigen mismatch for predicting donor-specific antibody development, rejection, and graft survival. Both may be useful tool for organ allocation and post-transplant care decision. And at the end, personalized medicine requires knowledge of precise alloimmune risk. I will stop here, and I'll be happy to answer all your questions. Thank you.